top 10 NIV and high-flow nasal cannula papers. We'll go over when NIV wins, high-flow nasal cannula hypothesis, the SOHO trial, helmet, post-extubation, ROX, and then ATS 2026. This is what you definitely have to know. So Brochard, NIV and hypercapnic respiratory failure, this is the foundational trial. This is New England Journal of Medicine, 1995. NIV is the standard of care for hypercapnic respiratory failure. Intubation was 26% versus 74%. Mortality 9% versus 29%. This is French ICUs, 85 patients. You can see here intubation, 26%. You can see mortality, the relative risk ratio 0.35 from 74% to 26%, but also hospital mortality. Below 7.25 NIV was insufficient. Above 7.35 NIV was optional, 1 hour response rule, no improvement, then you escalate. The mechanism why it works, because PEEP counteracts intrinsic auto PEEP from dynamic hyperinflation, decreases the work of breathing, the pressure support reduces the inspiratory muscle load. So taken together, directly addresses both drivers of hypercapnic respiratory failure. So this is why NIV works. So once again, there are two reasons why BiPAP works. It's the PEEP counteracting the auto PEEP, as well as the pressure support reducing the inspiratory muscle load. It's still the foundational trial after 30 plus years. So unlike high-flow nasal cannula evidence, which is shaken by the recent SOHO, the NIV and hypercapnic respiratory failure evidence has only gotten stronger. So the ATS 2026 gives us the strongest recommendation. And the Brochard trial, only 85 patients, but it was 1995 trial. So NIV and hypercapnic respiratory failure, remember intubation rates dropped, mortality improved from 29% to 9%. pH window and 1 hour response rule remains the clinical bedrock, still the standard of care. Okay, plant now. That was the Lancet 2000. This is NIV works on the general ward as well. No ICU is needed for pH 7.25 to 7.35. This is 236 patients in a UK general respiratory ward. You could see the treatment failure, 27%, in the NIV standard care, 40%. Mortality was 20% in the standard care, 10% in the NIV arm, so the relative risk 0.67. In hospital mortality was 10%. That relative risk ratio, by the way, is regarding intubation and death, but the 10% versus 20%, pH less than 7.25 was the threshold for ICU and intubation. Plant established the trained ward staff can safely deliver NIV. Acute exacerbation COPD patients 7.25 to 7.35 can be managed on the respiratory wards. So if I asked you, is there any evidence? Can the patient stay on the ward? And the answer is, yeah, if their pH is between 7.25 and 7.35, a very large UK trial, the plant trial. So remember, mortality decreases with the BiPAP, no ICUs needed, but less than 7.25, then you're really going into ICU. ATS 2026, again, strong recommendation. Then you have the Masip and actually Bersten and Masip trials, NIV and cardiogenic pulmonary edema. So NIV and CPAP is the first line in cardiogenic pulmonary edema. Bersten was only 39 patients, 1991, but then a meta-analysis, which is published in JAMA 2005, 15 randomized controlled trials, as well as the 3CPO trial of 1,069 patients published in the New England Journal of Medicine. So let's look at this intubation reduction in the Masip meta-analysis. CPAP significantly reduced it. Odds ratio 0.41. The intubation reduction was odds ratio 0.26. So BiPAP was even stronger intubation reduction than CPAP. So you were more, so it's like you're 60% less likely to be intubated if you were put on CPAP, but you were 75% less likely if you put on BiPAP. That was the initial meta-analysis, 2005. Bersten, intubation versus CPAP, original randomized control trial, 35% of standard care cardiogenic pulmonary edema patients needed intubation, but 0 in the CPAP arm. So the 2008 New England Journal of Medicine showed CPAP showed faster dyspnea relief, and there was no mortality benefit, but the NIV patients recovered faster. So the two unambiguous NIV wins are acute exacerbation COPD 7.25 to 7.35 and cardiogenic pulmonary edema. There is strong, consistent mortality or intubation evidence. And then, so that's what we have. So NIV, CPAP first line, and CPE, 0.41 and CPAP, 0.26 for intubation. So, we should look into the that meta-analysis in 2005 to see those numbers, because people often think, oh, CPAP is better than BiPAP, but actually BiPAP was better even for acute exacerbation COPD. Then we have the FLORALI trial, New England Journal of Medicine, 2015. This is the high-flow nasocannula mortality hypothesis. So you have PF ratio less than 300, 23 ICUs, France and Belgium. High-flow nasocannula, 38% intubation, 90-day mortality, 12%. Standard oxygen, 47% intubation, 90-day mortality, 23%. And the worst arm was actually NIV. What the FLORALI showed was that the trial failed its primary endpoint, intubation, but the mortality improvement was there. PF ratio less than 200, high-flow nasocannula did significantly better. NIV generated very large tidal volumes. Maybe that's why they had a worsened mortality compared to standard oxygen, high-flow nasocannula. So SOHO, which we'll see in a little bit, same investigators, 6 times larger, 1,000 plus patients, 42 ICUs. The mortality benefit wasn't there. There was no subgroup benefit. Intubation was a modest reduction. And so the mortality claim from FLORALI, which was 38% intubation versus 12% versus 23%, was a false positive. So FLORALI generated the hypothesis, SOHO closed it. You should teach both of them. High-flow nasal cannula is safe, reduces intubation modestly, but the mortality claim is not there. ATS still recommends high-flow nasal cannula for comfort, intubation reduction, but not really on mortality grounds. So this is the SOHO study just published, New England Journal of Medicine. So we're talking 1,110 patients. 42 French ICUs, primary endpoint, 28-day mortality, 14.6%. No mortality benefit. Number needed to treat. The only benefit is modest intubation reduction. There were 0 subgroups, and there was not one subgroup that was predefined, like a PF threshold, age, severity, diagnosis. This is the same investigators, REVA network, as the FLORALI, 6 times larger. Again, modest intubation reduction, improved dyspnea, mortality benefit is not there. So what's the takeaway from the SOHO trial? High-flow nasal cannula mortality was the same. No benefit in any subgroup. High-flow nasal cannula reduces intubation modestly, improves comfort. And we have, what about helmet NIV? This is the JAMA 2016 Patel, as well as the 2021 COVID trials, the Hernandez. So ARDS requiring NIV. You're looking at intubation, 18% with helmet versus 61% with face mask NIV. Absolute risk reduction, 43%. The mortality was significantly improved. Helmet versus high-flow nasal cannula in COVID, the intubation rates were much better with the helmet. So For a reason, the helmet wins over face mask. It's better PEEP, leak-free, high PEEP, comfort, tolerated longer, less P-silly, no mask leak. The helmet is not just a different interface, it changes the physiology. So helmet NIV, true trials to know Patel, and then the Hernandez 2021 confirmatory trial. Mechanism, it's better PEEP, comfort, less P-silly. The interface determines the outcome. We underuse the helmet NIV. And then everybody knows the Esteban, New England Journal of Medicine 2004, rescue NIV post-extubation is harmful. So this is this trial that 25% versus 14%, we're looking at post-extubation respiratory failure. It's not the time to use it. After post-extubation respiratory failure developed, standard oxygen mortality was 14%, and then rescue NIV and 25%. Time to reintubation, NIV delayed inevitable reintubation by 10 hours, and the reintubation rate was identical, 48%. So rescue NIV, applying NIV after failure develops is failure, delays the inevitable reintubation. Prophylactic NIV, which we're going to take a look at, that is beneficial. So remember, the ICU mortality is 25% versus 14%. And that's just the way it is. Thille, in New England Journal of Medicine 2019, this is different. This is high-risk post-extubation patients. You're giving it before they develop respiratory failure. This is a different concept. And this is the famous trial in 2019 where you alternate NIV and high-flow nasal cannula. The reintubation rates clearly better with NIV plus high-flow nasal cannula, 26% versus 39%. Relative risk, 0.67. No mortality difference, and that's an ATS 2026 strong recommendation. And so what are the high-risk criteria? Age greater than 65, cardiac failure, obesity, hypercapnia during weaning, weak cough, excessive secretions, 2 failed SBTs, prolonged mechanical ventilation. But even if you just remember age greater than 65, that is what you have to know. So prophylactic NIV and high-risk post-extubation, different population than the Esteban trial, and know the high-risk age, CHF, obesity, hypercapnia, but really no age greater than 65. And then you have to know paper number 9, ROCA, ICM 2019. This is the ROX Index. And how do we get this? It's the bedside tool that removes the guesswork from high-flow nasal cannula escalation. This is high-flow nasal cannula treated acute hypoxemic respiratory failure, 191 patients. We're looking at SpO2 over FiO2 divided by the respiratory rate. And you're doing it at 2, 6, and 12 hours. ROX less than 3.85, high risk escalate. If it's a ROS 3.85 to 4.88, then you're intermediate. And if ROX greater than 4.88, likely success. So 2, 6, 12 hours. So SOHO showed that high-flow nasal cannula doesn't save lives, but still widely used. And ROX provides an objective validated trigger. If it's less than 3.85 at 2 hours, better to intubate. That's your saturation divided by FiO2. So let's say you're 80%, 0.8, 80% divided by the FiO2 divided by the respiratory rate. And those are the numbers to remember. Less than 3.85 and then 4.88. And then the number 10 is the ATS 2026 guidelines. The operational Bible incorporates SOHO, Renovate, Thille, Hernandez into one algorithm. Acute hypoxemic respiratory failure, it still says high-flow nasal cannula strong. Monitor with the ROX, escalate if ROX less than 3.85. Pre-oxygenation before intubation is the first strong recommendation for high-flow nasal cannula outside hypoxemic respiratory failure. So you could use that right before intubation. Hypercapnic respiratory failure, we went over the Brochard plant Masip evidence base, but also for cardiogenic pulmonary edema. And then NIV strong post-extubation, high-risk patients, just to remember, CHF, obesity, hypercapnia, and then how every trial fits into this. Brochard, we went over, Masip, FLORALI, and SOHO. Patel was the ARDS, prefer helmet. Esteban, no rescue. Thille, post-extubation, and ROX is how you monitor stuff. You should know the Renovate, Brazilian multi-center, no mortality difference, high-flow nasal cannula versus NIV and acute respiratory failure. You should know PCILI, Hernandez we went over, and the previous ATS guidelines 2017, but now we have the most recent. So in short, we went over the Brochard, and then the plant, which showed you that it works on the floors. Masip and Bersten showed cardiogenic pulmonary edema, FLORALI and SOHO, the helmet, Esteban, Thille, ROX Index, and the ATS 2026 guidelines. Thank you.